Welcome back to another episode of Fertile Ground with Dr Jyoti. Today we're discussing a topic that brings a lot of anxiety to patients. Planning another pregnancy after a previously complicated pregnancy or traumatic birth. Whether a patient experienced severe preeclampsia, an unexpected premature delivery, or a really difficult labour, the thought of doing it again can be all too terrifying. Dr. Ruba, when a patient walks into your clinic carrying the trauma of a past complicated pregnancy, what's your starting point with them?
Usually it's lovely if we can see both people who might have been involved with the birth. Sometimes I just see the birth mother, but often the couple will come in together. And I think that's far more productive because we can then address everything and also see how the partner is feeling, because they're another witness to often this terrible trauma that's happened to this woman, whether it's psychological, physical, or both. And they are part of that journey, and they have to be part of that journey again. So seeing them whenever they're ready really is productive. Often if it has been a traumatic birth, whatever happened during that birth, sometimes if it takes place in a public hospital, they may offer a debrief session with the couple to see whether anything could have been done differently or better, and just talk the couple through what had happened during the birth. Sadly, often these couples are missed or they're seen to be coping well, so why do they need a debrief? So I do see a lot of couples who've been through difficult births, either here in Canberra or overseas or in other states in Australia. And it is useful for me to get the birth records and see if I can tease out what actually has happened with this couple. And whenever they're ready then to discuss those things, to have those notes in front of me during that consultation is very useful. And usually it's just, I think the terms of when that happens is dictated by when the couple is ready. And often that will be before contemplating another pregnancy because it has been so traumatic last time.
I suppose the question that will often be asked is, will this happen to me again? So if someone's had some of those severe complications, how do you assess their actual risk in the next pregnancy?
It's a good question. So I think it depends on the type of complication. Unfortunately, for a lot of complications of pregnancy, there are many risk factors, not just one risk factor. So there may be maternal age to consider. The older we are as women, the more complex our pregnancies and births can become. And we know as a population we are getting older when we have our first baby especially. So I think that's an important consideration, and unfortunately that doesn't improve over time. So that's always going to be a background factor if it was the first time. Then there are other things to consider. So what contributed perhaps to the preterm birth? Was it infection? Was it an early rupture of membranes? Could there have been other factors that might influence recurrence, like a structural issue with the uterus? Had that woman had a previous surgery to the cervix that structurally meant that the cervix and its integrity had been damaged? And there are some things we can do to try and mitigate that risk the next pregnancy.
Okay, and can you also touch on some of the steps you might take to reduce that risk?
So one of those things can be watching the cervix with ultrasound through the pregnancy, and sometimes in case of preterm birth, we also start progesterone pessaries, which are a hormone that basically seems to considerably reduce the risk of preterm birth if we start it from about 16 weeks of pregnancy. And I think it really depends on the etiology, the factors that caused the issues in the first place, as to quantifying recurrence of the risk. So, for instance, in maternal issues like preeclampsia, where the only cure for the preeclampsia is actually delivery of the baby, which may be premature if the preeclampsia is severe and of very early onset, say before 32 weeks. of pregnancy, then luckily there are some very simple things we can do the next time. Things like low-dose aspirin seems to reduce the recurrence risk of things like fetal growth restriction, things like preeclampsia, and particularly the early onset type of preeclampsia, which means premature birth.
I appreciate that there are many different things that can go wrong and that these questions need to be general in nature. But how does the type of complication that someone's had then dictate how long they should wait before trying again?
That's a good question. So it really does depend also on the recovery of the woman. So often, if it was complex, say for instance, a complex cesarean section, so different methods are used to try and deliver babies depending on gestation, depending on where the placenta lies, depending on the size of the baby. So all of these things and the way the baby's lying in the uterus may mean that instead of an incision that's made at the bottom of the uterus going from one side to the other, that sometimes we have to make a vertical incision on the uterus. And that indeed has a longer recovery time, and sometimes means that the incision on the abdomen has to be different as well, depending on whether it's planned or unplanned. It depends on how many weeks pregnant she was when she had her baby. So it may more be dependent on how long that baby was in special care for, and then other issues that might come with prematurity and how the couple's coping with the first baby that they have, and whether that baby is still having ongoing issues, then that might influence also when the couple feels ready to have their next pregnancy.
If I can get you to put your fertility hat on just for this one question, what can you do before getting pregnant to set someone up for a safer outcome?
I think maternal health is very important. So I think very simple things like trying to achieve a healthy body mass index, trying to control any other, what we term in medicine, we call it comorbidities. So things like if a woman is suffering from hypertension before she becomes pregnant, then good control of that, changing her medications to medications that are suitable and safe in pregnancy, paying attention to monitoring other parts of their health is important. So it may also be important to, for the male to be healthy as well in that relationship. If it's a male-female relationship, for them to start looking after themselves, stopping smoking, doing the basic things, taking some multivitamins, some folic acid, and then depending on how long they took to get pregnant last time and the distance or the space between pregnancies and the maternal age, then obviously sometimes cycles can change. So a woman's cycle can change. Sometimes it can become a little shorter with age. It can be more difficult to fall pregnant. So sometimes cycle monitoring might be useful to time ovulation and intercourse. So there's a few things that might be helpful in terms of fertility and monitoring and management in those women to also reduce their anxiety before they get pregnant, because they're already anxious about becoming pregnant, let alone getting pregnant. The whole conception, it can be also a challenge sometimes, particularly if they're feeling stressed about having another pregnancy and, of course, the birth. I think that gestational diabetes, it is very all-consuming. If women develop gestational diabetes, it means a lot of monitoring and finger pricks 4 times a day and recording it in a book and following a special diet. And then, there'll be a small percentage of women who require insulin, and that has its own challenges. And I think women are very, very conscious that everything they do could influence the health of their baby, so it makes them even more stressed. So lately the guidelines have been loosened a little bit, so not so many women are being caught in the net of screening for gestational diabetes, thank goodness, but it has a high recurrence risk because it has a genetic basis, and it also is related to age. So the older you are, the more common gestational diabetes is. And if you've had it in one pregnancy, then unfortunately you're at higher risk the second pregnancy. So we do earlier screening. And even screening before conception takes place is important. So that's why there are regular follow-ups arranged on a register for women who had previous gestational diabetes. So they're often advised, if they can, to undergo screening every couple of years, and then to see whether or not they may have developed insulin resistance or type 2 diabetes or glucose intolerance, whatever you'd like to call it, in between pregnancies. So probably a preconception test is warranted, and if it's been a little while, and then early testing in pregnancy is also important. And if that's normal, wonderful, but we do retest at around 26 to 28 weeks again, because insulin resistance starts increasing the further you get through the pregnancy. So then it's more common to diagnose gestational diabetes a little later. But if you pass that test, I have seen women who do not develop gestational diabetes the second time round when they've had it the first time round. But unfortunately, most ladies do.
So for a patient who's got anxiety about their next pregnancy, how do you approach their appointments? Is there anything different about these appointments?
I think that we try and offer them quick sort of appointments, so they're getting quickly to see me. So that also allays some of their anxiety, that they're able to quickly see someone, catch up with someone, and discuss the birth. Sometimes there may be parts of their memory that are missing from the birth because often they're busy pushing, or they've had a cesarean section, and sometimes it's all in a big rush and no one is explaining anything to them. So there can be parts of the information that can be missed, and that's why it's so critical to obtain as much information from the hospital where they delivered. And you can get things like the birth records, the birth summary, how did the baby do? Did the baby need the nursery? What was the weight of the baby? What were the issues around the time of birth? Were there issues going on antenatally? So were there signs that were missed along the way that maybe that person was at risk of high blood pressure or preterm birth or fetal growth restriction, or, a cesarean section might have been warranted before they were forced to have an induction of labour. So I think all of those things are vital to address. It can take more than one visit sometimes to address everything. Sometimes couples need to come back and have some reassurance or understand what's available. Sometimes they come from regional areas, and they often will travel to avoid having these complications happen again because they live in a regional place with fewer facilities. So often, that can definitely be managed usually between their local doctor and us, and then getting them up to Canberra at the right time.
So once someone receives that positive pregnancy test, the anxiety usually skyrockets. How does their care plan look different from a standard pregnancy, and how closely do you monitor them in those early weeks to give them that extra peace of mind?
I think it depends on the patient. Some patients do need a little bit of extra monitoring. It depends on the complication that's happened before. So if it's birth related, it may have not a lot to do with the pregnancy itself. So we could just have normal appointments, and then maybe they become a little bit more intense or more, a little longer. The further we get along in the pregnancy and the closer we get to birth. And often then people do become a lot more anxious if there was a birth-related complication. So whether that was anaesthetic related or obstetric related, perhaps it was instrumental delivery, perhaps it was bad tearing, perhaps it was blood loss. And so all of those things can be addressed, and we can be ready for those things this time round. And we can talk about ways of perhaps trying to avoid any of those issues.
Beautiful. Yeah, there's obviously, I know it's really hard because there's so many different examples of the way things go, but it's really nice to hear that you're able to plan. Even when you can't, you can still plan for the unplanned. Yeah, look, I really appreciate all of that. And thanks very much for your time, Dr. Jyoti.
Oh, thank you.
Thank you for listening to this episode of Fertile Ground with Dr. Jyoti Ruba. If you'd like to make an appointment with Dr. Jyoti, please visit her website at drruba.com.au. Or you can call her Canberra rooms on 02 6106 9991. We'll be back with a new episode soon, so go ahead and hit that subscribe to be alerted when the next one drops.